Welcome to the Oncology Journal Club podcast, a dynamic and engaging learning resource for medical professionals. I'm your producer, Rachel Babin from the Oncology podcast. Joining you today are your hosts, Professor Craig Underhill and Professor Christopher Jackson, along with our special guest, Professor Chris Karapetis. In this episode, we'll be diving into the key highlights from the recent ASCO GI meeting, breaking down the latest research and insights. For links to the papers discussed and bios of our hosts, head to the show notes at oncologynetwork.com.au. The Oncology Journal Club is proudly produced by the Oncology Network's podcast team. Thanks for tuning in. Let's get started.
Welcome everybody to this ASCO GI OJC special. It's a great pleasure to introduce Professor Chris Karapetis, or Christos as some of us call him, who's a professor of oncology at Flinders University, Flinders Medical Centre in Adelaide. I knew Chris way back to when he was at Guy's Hospital. Not long after, I was also a research fellow there, and Chris came back to Adelaide and set up the research unit. And so he just had his 25th year anniversary there, and I understand you got a surprise party, which was nice.
Yeah, no, it was nice. You sort of reflect when you're at a place for a long time at how things have changed, and they've certainly changed a lot since I started here. So there is something really nice about seeing all that development and seeing all the people that have kind of come along with you and people that have developed over the years and their careers have flourished, and just to think that you kind of helped out in a way. It's good. It was very kind of reassuring, affirming, and kind of made me feel old, but good.
Fantastic. Good on you. And it's not such a great pleasure to introduce Professor Chris Jackson, New Zealand. If anyone needs to turn on their closed captions, please do so now. Welcome, Chris.
Kia ora, Craig. That's the warmest introduction you've given me in a while. I think you must have been foreshadowing that I was going to say, geez, 25 years in one place and you're older than Craig. You're really old.
No, not. I think he's a couple of years younger than me.
No. CK had already known that's you that's really old.
Just to be clear, I was a very young oncologist when I returned from England. So
yeah,
I'm just a bit older.
It's only Craig that's older.
All right, let's get into it. So, Chris, what was the general vibe of the meeting? Because, of course, it all was happening in the midst of Trump inauguration and NCI announcements and stuff like that.
Yeah. So ASCO GI happened in San Francisco. It's a meeting that's been going on for a while. Originally, I think there were a few different cancer societies that sponsored it, but it was always kind of known as ASCO GI. The proper term for it is the Gastrointestinal Cancer Symposium, and now ASCO are the sole sponsors of the meeting. There were 4,000 people that attended, 3,000 attended in person, 1,000 had online only registration. So it's big, but not huge. And from Australia, there were only 4 people that were along, and from New Zealand, only 1. So the 5 of us bonded really well through the meeting. So yeah, very low numbers, I think, from this part of the world. The majority of attendees are actually from the US. I think something like 2,500 are US delegates. And then there's rest of the world. But yeah, it was kind of low numbers from this part of the world. I was there representing the AGITG and various things. And one of the big reasons I went along was to attend a rectal cancer task force meeting sponsored by the NCI. I prepared a presentation and we sort of talk about the latest research in the area of rectal cancer. So I arrived on the Tuesday, the day after the new administration, the Trump administration, had come in the US. And on the Wednesday, all NCI-sponsored meetings were cancelled. So my task force was cancelled. There were a number of people who had made the trip across to San Francisco from various parts of the US to be there for those meetings. Well, they were told to go home. And they were told that the American federal government is reprioritizing, establishing a new agenda. So things are certainly changing. And I think everybody was quite surprised that it was all happening so quickly. And one of the big issues and one of the big changes really is around the important issue around DEI, the diversity, equity, and inclusion themes that run so deep, I think, across all aspects of cancer and research and through organizational structures and strategies. Well, one particular organizational structure, and that is the federal government of the US, is changing all of that and doing it very, very quickly. And that's going to have a flow-on effect that's going to affect research, I think, in a major way. ASCO, I'm pleased to say, the feeling I got in talking to various people is that they are definitely holding firm around their policy and strategy, which is deeply rooted in equity. One of the previous presidents of ASCO would often refer to equity: every patient, every day, everywhere, across research, education, and quality. I think that's still ringing true through that organization. It was still a good meeting, but that task force meeting didn't happen, unfortunately.
Was there any discussion about the DA stuff?
Yeah, look, there was a really good lecture on day one. It was the keynote lecture of the meeting. The lecturer was Pamela Coons, who works at the Yale School of Medicine. She's a recognized expert in neuroendocrine tumors of the GI tract in particular. And she gave the keynote, which was titled Shattering Barriers with Inclusive Science. And she really focused on diversity, equity, inclusion, and B, there's a DEI, B. The B is belonging. And she gave an excellent presentation on the importance of all of these aspects of not just research, but of policy and of care. She gave a really good presentation. It was actually quite personal. She described her own personal experience of gender discrimination, talked about how one of the highlights of her life was giving a presentation at the ASCO annual meeting, results of a big phase 3 trial that she had led. But then what followed on from that, she said, was a very difficult period for her in managing discrimination that was based mainly on gender. And she gave a number of examples of how it affected her and how it affected her career. And at the end of her presentation, there were a number of questions from really concerned researchers saying, what's going to happen to me now? What's going to happen to my research? What's going to happen to my grants? And these are researchers, some of whom are really focused on these issues as part of their research projects. What happens to their research? No one's quite sure what's going to happen. We know that there are major changes, but it was just amazing how quickly the situation has changed. I'm really hopeful that ASCO will stay kind of true and firm in continuing to support the DEI themes through everything that they do. They've done a lot of work in this area over the last 20 or 30 years. It's just crazy to think that they can undo it. I consider it to be so kind of embedded in their ethos.
Yeah, I agree.
Yeah, and I think also a lot of it is not just in their backyard, but it's also in our own backyard too. I mean, New Zealand abolished Te Aka Whaiora, which was the Māori Health Authority last year, following on from an election which moved to a more right-wing / populist style government. So these political changes do have a big impact on people. And they're not just things that happen overseas, they're things that happen in our own backyard as well. That said, here we are, 3 white blokes in a podcast, about diversity, inclusion, etc. But, I think one of the key things is DEI isn't about diversity, equity, and inclusion. What it's about is not excluding people. And since when did not excluding people become a controversial thing? Frankly, it's a bit daft.
ASCO, you mentioned, it's an international organisation in effect. So hopefully they won't just sort of acquiesce to this.
Yeah, no, I hope so too. And I mean, there are a number of international colleagues that I met with who were kind of grumbling about the changes, and some are actually saying that they will probably change their mind about attending the ASCO annual scientific meeting on the back of these changes. So, but I agree with you. I do see ASCO as very much an international organization. If you look at membership at the ASM, if you look at attendance, it's very international. So hopefully they'll stick true to their...
Lancet, of course, has also just declared themselves as the watchdog on the US administration and how they're going to impact on change. That's in the Lancet editorial from last month. And of course, New England Journal of Medicine ran a series of reckoning of its own history of unconscious bias and racism as well. So I hope all of those journals and all of those organisations stay true to the principles they've preached over the last couple of years and double down and show actually as professions and professionals, we have standards and we must stand up for those at every possible opportunity.
Yeah, and for, as a regional cancer clinician, I mean, is the equity issues is sort of at the heart of everything we do. So, yeah, let's hope people don't just collaborate with this, because I think that's part of it. Like cancelling those sessions seems to be, people are more worried about what they do if they proceeded. What are they really going to do if you still had a discussion about rectal cancer, seems a bit odd. Anyway, let's get into the science discussion, try and lift the mood. Looked like to be some really interesting stuff. Christos, what do you think was some of the top scientific abstracts presented?
The first study I'll talk about comes out of Japan. It was a study that is known as the DEEPER study.
Of course, so that's cetuximab, shows greater benefit than bevacizumab when combined with first-line mFOLFOXIRI in left-sided RAS BRAF wild-type metastatic colorectal cancer. So can you firstly just explain, again, we have a general audience, I may not be fully across it, but what's the significance that this was a study in left-sided metastatic colorectal cancer?
That's right. So it wasn't. It started off as a study in colorectal cancer that was right and left-sided initially, and it really wanted to ask the question, is bevacizumab better or is an anti-EGFR antibody, in this case cetuximab, better when combined with chemotherapy? And they said, let's just choose the best chemo, the one that produces the highest response rate. We're only going to include really fit patients. And so the regimen they've chosen is the regimen that combines fluorouracil and oxaliplatin and irinotecan. So everybody got the triplet chemotherapy. And so the randomization was between bevacizumab, the VEGF targeting monoclonal antibody, and cetuximab, the EGFR targeting monoclonal antibody. So it started off right and left, but as data was emerging, it really provided fairly convincing evidence that for the right-sided tumors, you're better off starting with bevacizumab. They actually stopped randomization in the right-sided group and continued with left-sided only. And so they presented findings from the left-sided metastatic colorectal cancer cohort. They were all RAS wild types. That's important. They were patients that were considered patients that could benefit from treatment with an EGFR antibody. And as I said, they all got triplet chemotherapy. And so they presented the findings. The primary endpoint was depth of response. So that's really a measure of how much smaller the tumors actually get when you add them up in the absence of any progression. So no new lesions, no PD, but you then kind of add up the diameters of the tumor and see how small they get. So that was their primary endpoint. They were hoping to demonstrate that the EGFR antibody, I think, would produce a greater depth of response. There was some data in the lead up to this randomized trial that this was the case. And so they presented the findings around depth of response, which they, again, demonstrated through this. That was one of the primary endpoints. There was a greater depth of response with the EGFR antibody versus bevacizumab. They looked at just overall response rate, standard RECIST overall response rate, and there was no real difference when you looked at that. And disease control rates were not really different. R0 resection rate, so the number of patients had such a good response that they go on and have surgery. It was about the same. The duration of response was longer with cetuximab. They looked at progression-free survival, which was better with cetuximab particularly in the RAS and BRAF wild-type group, and overall survival was trending for better with cetuximab. The median overall survival was 50 months with cetuximab versus 40 months with bevacizumab. So, we're getting reasonably long survival times now in these studies. When one considers, I think when we started treating metastatic colorectal cancer, not many patients were living sort of longer than 12 months. So we're getting sort of median OSs in the kind of, 40 and 50 month territory, which is an improvement. It was especially longer in those patients with extrahepatic metastatic disease. So there's some interesting subgroup analyses. So I think this study's providing some evidence that would favor the use of the EGFR antibody over bevacizumab in RAS, BRAF wild-type left-sided cancer, especially if you're looking for kind of maybe a deep, longer response. We can argue whether that particular clinical endpoint is a clinically meaningful one. But there is a suggestion that PFS and overall survival are better. So I think that was interesting and would probably support a clinical decision around using an EGFR antibody for left-sided disease over using bevacizumab as first line in that RAS wild-type, BRAF wild-type group. So
Craig, I'm going to get Chris and Craig. I'm going to get stuck right in to a couple of those comments there, Chris. Let's start by talking about that primary endpoint of depth of response. What is your view on that endpoint?
As I said, I don't usually consider that in my clinical practice. It's not as though I would look at or try to quantify that depth of response in practice. So it's very much an endpoint that I'd consider research related. But there is data that talks to the patients that have a greater depth of response also being patients that have a better survival. So there may be a true clinical benefit that translates out into that OS benefit.
Yeah, but it's an unvalidated surrogate, right? When you've already got OS data,
correct,
for the primary endpoint, which shows it's no different for the primary endpoint, then it becomes a bit meaningless, doesn't it? So, I mean, the pharmaceutical company's done that a couple of times with the depth of response endpoint. I think we should reject it. In terms of the overall interpretation of the study, Chris, a couple of things that stand out to me. The median overall survival of 50 months, as you say, that's massive. I
want it to be better than that.
Oh, but it's massive though, right? I mean, what was the other studies of triplet based?
But look, as I said, this is FOLFOX series. So these patients are selected.
Yeah.
We're looking at people without any comorbidity, people that are considered fit, well, and good enough to receive a triplet chemo. And then on top of that, they get a monoclonal antibody. So there's clearly a selection bias that's going to push that OS out, in this study, and that's understood. But it's consistent across two arms, and we still see this difference in PFS, OS. I think it's interesting seeing the difference in those with extrahepatic disease. I think that just talks to the disease burden. So we know that liver's often involved. Some evidence that suggests that Bev may be particularly beneficial with liver involvement, but again, when you're looking at trying to get the total burden of disease under control, I think the EGFR antibodies are active, and they can provide that kind of disease control that may translate into a survival benefit.
I mean, that is really interesting, isn't it, for that's it, isn't it? So it's a couple of things. First of all, around the median overall survival, because, the seminal study of triplet chemotherapy was the TRIBE study, FOLFOXIRI versus FOLFIRI-BEV.
Yeah.
And their MOS was about 30-odd months. It's a long time ago now, 10 plus years ago, but it's 30 months. This is a really big increment, isn't it, without any different drugs. So as you say, I think they probably are selecting quite heavily in that group, and that's probably appropriate. I mean, would you use FOLFOXIRI in many incurable patients these days, Chris? In incurable patients, no.
No, I don't. And I mean, obviously we've got toxicity concerns. I'm still not entirely convinced that the triplet provides a survival benefit over, proper use of sequencing treatments. So,
So that is important, isn't it? And then the other thing there as well, does it take us any further forward than the other studies of cetuximab in left-sided colorectal cancer versus bevacizumab in left-sided colorectal cancer, like the CALGB study?
Yeah, I think there, as you say, there is evidence around the benefit of EGFR antibody use for left-sided RAS, BRAF wild-type disease from the start. And so this is really a study that just adds that additional kind of confirmation that left-sided disease is the disease where you need to consider it in first line over a bevacizumab. And again, we've got a signal here of a potential survival benefit. So it kind of supports what I would say should represent optimal first-line practice. It's consistent with the NCCN guidelines. The use of EGFR antibodies in first line is there. Now, whether you use it with a triplet or a doublet, as I said, in my practice, I'd be usually using it with a doublet, not a triplet.
Chris, I saw it as kind of practice affirming because we've already seen, as you mentioned, NCCN guidelines, ESMO guidelines, ASCO guidelines, they all suggesting for the left-sided tumours to use an EGFR inhibitor rather than a VEGF inhibitor. So this kind of fits that narrative, doesn't it?
I agree.
The other thing about the liver-limited versus the extrahepatic is that extrahepatic is also going to be the peritoneal disease, isn't it? And they're the ones which we think about as going really badly quite quickly. And that gives a degree, to me, when I look at the degree of comfort of using EGFR in that group, rather than perhaps having it for later lines of therapy. And Chris, you are Mr. K-Raz and Professor K-Raz and Professor cetuximab in Australia, Southern Mister. So you'll still think that its role sits in first line, Chris, in all patients rather than second or third line?
For cetuximab, I think for left-sided disease, yes. For right-sided disease, my standard practice would be to prefer bevacizumab, given the clinical trial data, and I'd be coming in with EGFR antibodies in the second or third line. There was another really interesting study that was looking at bringing EGFR antibody treatment into first line, but this is specifically in the BRAF-mutant subgroup. This is the BREAKWATER trial.
First line combination EC and FOLFOX6, improving outcomes in BRAF V600E mutant and metastatic colorectal cancer, offering a new standard of care. Big call.
Big call, yeah. So we're looking at EC's encorafenib, cetuximab, which I think many people are familiar with, the Beacon study, which was a second-line study for patients with BRAF mutation positive metastatic colorectal cancer. The BRAF mutation really confers an aggressive type of tumor biology. Usually we're talking about cancers that can be fast-growing, relatively chemo-refractory, bad prognosis, unfortunately. So the Beacon study, a second-line study, did demonstrate a survival benefit in using encorafenib with cetuximab after prior chemotherapy. The BREAKWATER study is looking at bringing that into the first line, again for BRAF mutation, V600E, metastatic colorectal cancer, comparing the combination of chemotherapy with FOLFOX, which is a kind of a regimen that many people are very, very familiar with, combined with encorafenib, cetuximab, comparing it to standard of care. So standard of care could have actually been FOLFOXIRI, it was for some patients. It could have been capecitabine and oxaliplatin, FOLFOX, and with or without bevacizumab. And the study's primary endpoints were response rate and progression-free survival. So at this meeting, we saw the response rate data, and the response rate data did favor the arm that included the EC, encorafenib, cetuximab. It was an almost 61% response rate versus 40% response with the standard of care chemo arm. The duration of response was also longer. So if we look at the proportion of patients that have a response that lasts a year or more, it was 22%. So sort of 1 in 5 will have a response that lasts a year or more with the encorafenib, cetuximab added in, versus half that, 11% with standard of care. There was an interim overall survival analysis that did look quite promising, but it was interim. The alpha was set ridiculously high, and what we saw was a 12-month survival of 79% with the encorafenib, cetuximab versus 66% with standard of care. So a numerical advantage, but at an interim level with an alpha set at 0.00001 or whatever, it wasn't statistically significant. So positive for response rate, responses that last longer, and we did see a statement from Amgen. This was a sponsored study by Amgen, and they did release a press release following the meeting to say that the second primary endpoint of progression-free survival was met. It was positive, favouring encorafenib cetuximab. I think that data will be presented either at the AACR meeting in April or possibly ASCO in June. So we're waiting for that.
So I noticed that, I'm going to throw to Chris, but I noticed if FDA's actually gave accelerated approval for this combination. I think it'll be a while before we see it in our own jurisdictions, and obviously we need that longer follow-up, but again, interesting study. Chris Jackson?
Yeah, look, I'm really excited about this study because, of course, Beacon was a second and subsequent lines of therapy study, wasn't it? So it was following on from chemo, and BREAKWATER's first line. So do you combine it with chemo or do you just use it on its own? And this really seems to point very, very strongly to the combination, doesn't it?
It does. Yeah, I mean, there are toxicity issues that many people involved in kind of managing patients with colorectal cancer are now quite across. You do get more rash, obviously, with the EGFR antibodies. You get more asthenia, pyrexia with encorafenib, but those toxicities are manageable, but you need to obviously take that into account.
Well, so EncoCetux had quality of life data, which was better than chemotherapy in Beacon, right? I mean, for a couple of reasons. One, because the combo is not chemotherapy and that got marketed as non-chemotherapy. But second of all, they lived longer. And if you live longer, you have better quality of life in general, eh? But when you're combining 2 drugs plus chemo, which in this study was 2 drugs or 3 drugs, there's a real question about synergistic or additive toxicities, right? Did you see much of that coming through, Chris, in terms of the quality of life stuff or signals that made you, as a clinician, worry about this combo?
Yeah, look, I think, as I say, I think it's important to take into account the toxicity and kind of making decisions around whether you're going to prefer to go with an approach that brings in the BRAF targeting from first line versus second line. But they didn't present quality of life data. I'm sure that's coming. But I didn't see, an indication that we were seeing significantly more of the toxicities that we're familiar with. And the other thing is that we're actually quite familiar with using drugs like cetuximab or panitumumab combined with FOLFOX. It's not a new regimen, really. We're doing that already in the treatment of metastatic colorectal cancer first line. The big difference is adding in the encorafenib, the management of that.
Were you seeing on treatment deaths at all, Chris? Things like deaths on treatment deaths or anything like that?
No. The interim overall survival data does suggest that we're going to probably see a true survival benefit.
Yeah, which is exciting, eh? And also there's panitumumab with dabrafenib, isn't there, in second subsequent line as a competitor, basically. Do you see this as a class effect, or do you think this is going to be agent-specific?
Class effect, I suspect.
We'll be hitting the target, is that?
Yeah, that's right. So we certainly see remarkable similarity between panitumumab and cetuximab in terms of anti-tumor effect. We do see differences in toxicities, so you get hypersensitivity reactions with one when you may not get it with the other. So they're not the same drug, but in terms of their anti-tumor effect, the efficacy data are remarkably similar. And same with the TKIs. You get some TKIs that will cause more asthenia, pyrexia, others that will cause more rash and diarrhea. So they do differ, and I think it's definitely worth shifting from one to the other in a patient that's tolerating one poorly, especially if the efficacy data looks similar.
All right, it's good. I'm glad Chris is excited.
I think that one gets a bouquet for aiming for overall survival and PFS data, so it gets a bouquet. The last one gets both a brickbat and a bouquet, brickbat having a crappy primary endpoint in the first instance, but a bouquet for actually showing overall survival gains. So a bit of a mix.
Fantastic. Glad you're both excited about that. Does seem like a potential leap forward, but it's a watch this space for some further data. But while we're on the targeted therapy topic, Chris, do you want to talk about this new pan-RAS inhibitor that was...
This is remarkable for the fact that it was just a poster. So this didn't make it to any of the oral sessions, the main oral session, or even the rapid fire oral session. You had to sort of seek this out as a poster, but it got a lot of interest, right? Because we're seeing multi-selective RAS. This is a RAS-on tricomplex inhibitor that is showing a significant degree of activity. They looked at patients with pancreatic cancer who had RAS mutations, and pretty much every case of pancreatic cancer will have a RAS mutation. These were specifically G12 mutations, not including G12C, All of the patients had prior chemotherapy, good performance status, and they presented waterfall plots where, it's one of these sort of diagrams where just about every tumor got smaller. In terms of actually reaching the degree of shrinkage to call it a response, the actual response rate was 36%, but impressive water plots. This is the sort of early phase data. There is a phase 3 second-line trial that has started. The sponsor is a company named Revolution Medicines. And so these drugs are moving forward in clinical development quite quickly. We do need randomized data and to actually demonstrate survival benefit. These medicines will be costly both in terms of financial costs, I'm sure, but also toxicities. There are significant toxicity issues that need to be considered. There's a lot of grade 1-2 toxicity, and I know we sometimes tend to underemphasize the importance of grade 1-2, but it does have a major impact on quality of life. So things like rash, diarrhea, fatigue, asthenia, pretty common. So, you'd really want to see survival benefit come through in these phase 3 studies, but certainly exciting. And, when it comes to pancreatic cancer, we need to be doing so much better than second line chemotherapy. Yeah.
Chris, we've talked about a lot on the podcast about these persistent but low grade toxicities that, can have quite a substantial impact on people's quality of life. So there was a lot of press about this paper. So it was in pancreas cancer. They were RAS mutated. The RAS mutation is quite high in pancreas cancer. We've had KRAS G12C inhibitors on the market, sotorasib in lung cancer, and also adagrasib in non-small cell lung cancer and colorectal cancer. And this one's even less pronounceable. Can you say it, Chris?
Daraxonrasib. Look, it'll have a better name than that when it finally kind of...
Yeah, but I think because it's an unmet need, isn't it, having a RAS mutant that's not specific to the subtype, the 12C or 12D, etc. So I think that's probably why this had quite a bit of attention.
Yeah. They did some interesting research as well, looking at RAS allele frequency in blood samples, and they did see that there was a significant reduction in the RAS mutation allele frequency rate. So there was a sort of a molecular response, and those molecular responders had a really good period of disease control, progression-free survival. So this is definitely biologically active, and hopefully the phase 3 studies will prove that these medicines provide a survival benefit.
Yeah, it's really important to, look at them either alone or in combination with chemotherapy in a randomized way, isn't it? We've seen that a lot, and they've promised a lot because it was supposed to be a targeted EGFR, didn't deliver very much. Aleprib and the PARP subgroup, nice idea, but, the OS data didn't pan out so well. So you're right, we do need the randomized data there. Chris really strongly endorsed that comment. But as you say, this is a really high mutation frequency, 75% plus of pancreas cancers, a really important target. So it is a really huge watch the space, isn't it?
It is. It's huge, I think. They got a median survival in this study. And again, this is sort of phase 1-2 data of over 12 months in sort of second line. So I do want to see phase 3 data, but it certainly looks promising.
Yeah, it'll get to first line pretty quick, won't it?
Yeah, I expect so.
So, Chris, let's switch tack. What about Alaska aspirin? From the sublime to the ridiculous, from the multi-thousands of dollars targeted therapy to something of patent. Tell us about this study. Now, it was adjuvant low dose aspirin in colorectal cancer or Alaska.
Yeah, that's what the study is looking at. But they did something really clever, and they basically performed genomic testing on the cancers. These were all stage 1 to stage 3, some very early stage as well. They included rectal, or the rectals were stage 1 to 3, and the colon was stage 2 and 3. And they looked particularly for PIK3CA somatic mutations, exon 9, exon 20, and other PIK3CA mutations. So they had a cohort A, which was the exon 9 and 20 group, and the others were a cohort B. But both cohorts benefited significantly from aspirin in terms of reducing the risk of Colorectal cancer recurrence, the hazard ratio was 0.49, and reducing or improving disease-free survival at 3 years from 81% to 88%. So, that's a significant proportional reduction of, so 40% if you do the math. It's actually quite a significant improvement. And that's through giving aspirin at a dose of 160 milligrams for 3 years. So I looked at the data. This is proper prospective randomized control data. It stems from a group based at Karolinska in Sweden. The patients were recruited across the Scandinavian countries, reasonable numbers, over 300 patients in each cohort. Interestingly, it only made it into the mini oral sessions. They're like sort of the tantalizing tidbits rather than the real deal that make it into the oral. But I looked at that and I thought, gee, I think we've got something here, and we should start looking at PIK3CA for our patients with resected stage 2 and stage 3 colon cancer and rectal cancer. And it's a 3-year program. I mean, there were the recognized risks of aspirin, but the risks were quite low, within this cohort, the bleeding risk, obviously, and a significant difference in the disease-free survival and colorectal cancer recurrence risk. So I kind of saw this as potentially practice-changing, but I don't think any of us are routinely checking for PIK3CA somatic mutations currently.
You read my mind. Is that not something that's routinely done now, especially in the early stages? Should we be testing people?
Well, that's what the data from the Alaska study indicates, that we should be testing, and we should be discussing aspirin use in patients that have PIK3CA mutations. This study was really based on a number of studies that looked at the benefit of aspirin in this group, but these were mainly retrospective or population-based cohort studies, but they have suggested a benefit in the patients with PIK3CA mutation, somatic mutation positive colorectal cancer. This is a prospective randomized controlled trial showing a benefit.
Yeah.
I kind of think we're there. I just looked at it and I thought, if aspirin was a really expensive, molecular targeted or tyrosine kinase inhibitor, this would be a plenary at ASCO.
So, Chris Jackson, can I ask you, are you going to start testing for your patients now for mutations?
Look, I think that the thing is that the PI3 kinase mutation testing is not funded, Craig, and the paper's not even been published yet, so we get a wee bit ahead of ourselves to talk about funding and reimbursement, I think. But and also we've got data from ASCO. There must be the AGITG ASCO tissue sub-study, which must be due or overdue at least.
It's overdue. It's coming. I can tell you, and PIK3CA is definitely something that's being tested. And so there'll be effectively to be a retrospective ad hoc analysis looking back at the experience and the outcomes and dividing by PIK3CA status. So that'd be very interesting, I think.
And if that's confirmatory, then we're there, right? I mean, I must confess I did send this study straight on to my pathologist when it was announced and said, coming to a path lab near you, and asked him to edit. And with colorectal, we're getting close to lung in terms of the relevant actionable mutations, in terms of mismatch repair, microsatellite stability, REF-RAS, PIK3 kinase now as well, and HER2 expression also. Once you get up to 6, 7, 8 immunohistochemical stains, you're looking at, really, it's almost getting cheaper to an NGS if the NGS can get down to the $1,000 mark. So I think we're going to get there very, very soon.
I agree. I think we're getting to a point where any cancer that's considered advanced, at least including locally advanced, will probably be tested, more comprehensively when it comes to genomic mutations, because I think it's going to have a bearing on our treatment recommendations. So
fantastic.
And the ASCO study, the only other problem with the ASCO study was people who were on aspirin aspirin and omeprazole PPI were excluded, and we found when we were recruiting for that study that, half or more of our patients were actually on omeprazole, so we couldn't put them in. And so we took the approach while that study was ongoing, just to give everyone who had another indication, such as hypertension or cardiovascular disease, aspirin or high cardiovascular risk, until ASCO came out as negative.
Fantastic. We're running out of time. We can't finish a podcast without talking about immunotherapy, even in the GI settings.
In colorectal cancer, there were two big kind of immunotherapy presentations. One was the Checkmate AHW study, which was a study that looked at patients with deficient mismatch repair, metastatic colorectal cancer. They could come into it after previous chemo. They could come into it first line. So it was a mixture of stages in terms of their cancer treatment or had good performance status. So there were 3 arms in the study. It was a 2-2-1 randomization. The first arm was Nivo alone. The second arm was Ipi-Nivo. And the third arm was a standard of care chemo arm. So what we saw at the ASCO GI meeting this year was the comparison of Nivo alone versus Ipi-Nivo. So we already know that immune therapy is better than chemotherapy for metastatic colorectal cancer with deficiency in mismatch repair or microsatellite instability. We already know that. So this is now saying which is the best immune therapy. Is combination IO better than just PD-1 targeting immune therapy? And the answer is combination is better. The progression-free survival hazard ratio was 0.62. The response rate was higher. Yes, there were more adverse events, mainly endocrine events, things like adrenal insufficiency. You do see more of that with Ipi, but there was definitely a benefit. This was Ipi-Nivo, where the Ipi is given just 4 times every 3 weeks, 1 milligram per kilogram was the dose. And then after that, you continued maintenance Nivo. But there was a PFS benefit with a combination. So that was interesting. And the other immune therapy study that was interesting was a study known as Resect-C, which was a study that came out of Denmark. And this looked at giving patients with early stage colon cancer, again, deficient mismatch repair, just 1 cycle of pembrolizumab. And it kind of showed us what other studies have shown us in this setting, that you do get significant response. You get a high rate of pathological CR. This is just with 1 dose. It was a 44% path CR rate and a 57% major path response. Higher actually for those cancers that were considered to be stage 1, stage 2 clinically. It's always a bit difficult to stage cancers like this clinically, but there was 61% path CR if it was stage 1 or 2 cancer. So, this is tantalizing. Maybe we'll be moving towards using just immune therapy and avoiding surgery. But we're not quite there yet. It's just really exciting, I think.
Which is a small population, isn't it? But a really important one to discover, which is why, everyone these days is getting MMR or MSI testing as standard, right?
Correct. It's you don't even have to ask for it now. It's going to happen, I think.
Chris, I think HW is a really important study because everyone has been using immune monotherapy versus chemotherapy. We knew that. And 8HW was 3-arm, but they'd only reported 2 of them, which I never quite understood. So we didn't actually know if combination IO was better than monotherapy, right? And this really does suggest, or does suggest to me, what's your opinion? Do you think it does confirm to your satisfaction that combination IO is better than monotherapy in this group?
No, it does. Look, I think we're going to see that this group of patients are going to have clinical outcome improvements that start to mirror what we see with melanoma, where we're already seeing incredibly durable responses with relatively short courses of IO. So this is a really immune therapy responsive group. And in the melanoma world, we know that combination IO is more likely to give you a durable, complete response, i.e., always reluctant to use the word cure, but cure is, I think, what we're seeing in melanoma. And I think there are going to be some patients that have deficient mismatch repair metastatic colorectal cancer that are going to have responses that last for many years, and you're more likely to get that with the combination. Again, it's about patient selection because you will get more toxicity, and we need a bit more data.
Anything on subgroups like liver-only group, for example, because liver's an immunosuppressive phenotype, isn't it? So was that a factor at all?
Every group, I think, benefited from the combination, yeah.
Every group. Well, that is really important to have combination versus monotherapy is largely settled on PFS at least, if not on OS.
Yep.
Alrighty. Fantastic discussion, gents. Well done. Sounds like it was a great meeting, Chris, even though there was not great representation from this part of the world, but some exciting data.
I spent some great time with Michael Jamieson from New Zealand as he presented SPA. And it was really, this is where the face-to-face meetings become really useful because we met up with a researcher from Tata Memorial in Mumbai who had basically he was a lead investigator on a trial that did exactly what SPA did. And this was a study that looked at combining chemoradiotherapy with a statin for patients with rectal cancer, operable rectal cancer. We met with this fellow and are looking at potentially combining data sets, and I think a lot of good things will come from it. And it was just great spending time with Michael. He had a poster there, really interesting poster that does suggest that statins may provide a benefit, but we need more research, obviously. So
wonderful. All right. Thank you both for a great discussion. Thanks, Chris, for taking the time to come on the podcast. Thanks, Chris Jackson. And hopefully we'll see each other face to face soon. Thanks again, Rachel. Look forward to some feedback from our listeners on today's episode. And if you may also want to sign up for the Oncology News Australia newsletters. We'll put the link and people can sign up for some regular oncology news. All right.
Well, happy birthday to you too, Craig. And
thank you.
I know that listeners can only hear you, not see you, but I'd just like to assure everyone he doesn't look a day over 70.
Ah, dear. Touche. All right. See you later.
thank you.
Thank you for tuning in to the Oncology Journal Club podcast, proudly brought to you by the Oncology Podcast, part of the Oncology Network. For healthcare professionals seeking regular news updates and insightful discussions, we invite you to join our community at oncologynetwork.com.au. Your free registration includes a complimentary subscription to our weekly publication, the Oncology Newsletter, a valuable resource to stay updated on the latest advancements in the field. We value your input and welcome your feedback and paper recommendations via our social media channels, email and website. Your insights help shape the conversation and drive the direction of future episodes. This is Rachel Babin signing off for the Oncology Journal Club podcast.